Good afternoon, and welcome to HealthSystemCIO.com's All-Star Panel, Preparing for an eCQM World, a complimentary webinar from HealthSystemCIO.com, sponsored by Encore, a Quintiles company. Just a little housekeeping before we get started today. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I'll be your moderator today. We encourage you to ask questions during our event. You type them into the lower right-hand corner of your screen in the Q&A box, leave the default set to all panelists, and send them in as they occur to you. We will take them later on in the program. You can download the deck by using the URL on your screen, or you have a shortened URL at the bottom of all slides. And we are recording today's event, so we will have an archive available within 2 business days, if not sooner, and we'll let you know by email as soon as that's been posted to our YouTube channel. Just so you see how we're going to spend our time today, first we're going to go about 35 minutes with our main panel discussion. We've got as our guest Melinda Costin, VP and CIO at JPS Health Network, Dr. Keith Wolche, VP and CMIO at BJC Healthcare, and Liz Richard, Managing Director of Value Realization Solutions with Encore. And then we'll take your questions. We've got some bio information up for the folks who will be speaking, which we will post while they are speaking. So without further delay, we're going to jump right into our conversation. And I'd like each of our panelists to give us an overview of their organizations. Melinda?
Yes, it's a joy to do this, and thank you for including us. We're JPS Health Network. That kind of sounds like a network of physicians, but it's really a network of a hospital of 535 beds and 50 clinics. Of those 50 clinics, 20 of them are school-based. So we are the public hospital for Tarrant County, where Fort Worth and several other cities are located. We're kind of a sister to Parkland, which is the public hospital for Dallas County. We're the public hospital for Tarrant County. We are the only level 1 trauma center in the county. We have a very strong presence in behavioral health. We have a psychiatric emergency center. We do handle all of the jail patients as well. We have a very strong teaching hospital program, a residency program, particularly the largest, actually, residency program for family practice. And we do care, of course, for all of the underserved. We have about 4,000 charity-eligible connection members, people who we ourselves insure and care for. Any questions about that?
No, I think that's good enough for now.
Okay,
Dr. Wolche?
great.
Yeah, thank you. I'm at BJC Healthcare based out of St. Louis, Missouri. We cover the eastern side of Missouri and parts of southwest Illinois. We have 12 hospitals in our system. The largest is Barnes-Jewish Hospital, and then we have a pediatric hospital, St. Louis Children's, our academic anchors in partnership with Washington University School of Medicine. But from our 1,200-bed, tertiary care referral center, level 1 trauma center, safety net hospital, we go all the way down to less than 10-bed safety net, rural hospitals. We have about 27,000 employees, over 4,000 physicians, and in the system overall about 3,500 staffed beds. We do have some employed physicians, but a lot of our hospitals have non-employed physicians who admit to them. So we really cover the gamut of healthcare here in the mid-Missouri and southwest Illinois.
Excellent. Liz, you want to tell us a little bit about Encore?
Sure. This is Liz Richard, and I am with Encore, a Quintiles company, and we're a leader in health information technology and analytics service, and we're focused on accelerating value and return on healthcare providers' IT investments. And we have a team of world-class industry experts with extensive knowledge on all things healthcare, IT, and any requirements surrounding healthcare IT, including e-measures. We've been named one of modern healthcare's best places to work, and we've been recognized as a consistently high performer by class. And we really focus on the value we provide to our clients, and we back that up with a commitment to the highest levels of client satisfaction, and that's something that we call 100% referenceability.
Excellent. Very good. Melinda, I'd like to start with you on this question. Let's talk about the challenge of moving to eCQMs and the work you've done in this area.
Absolutely. So we began, and we were fortunate that we began over 3 years ago, by assigning a specific individual to track all of the CMS activity and requirements for us and totally manage our Meaningful Use program. She is a nurse with a strong clinical background, certified in nursing informatics, and that was kind of key to us because she works continually with our development staff. We are an EPIC site, so she works very closely with all of our clinicians and other developers on our EPIC system. But much more importantly, she works on a continuing basis with our direct caregivers, our physicians and our nurses and our allied health professionals, to help them understand what is the significance of meaningful use and the quality measures, why do we have them, and then what specifically do they need to do to make sure we're meeting the needs and what the importance of those needs are, that they're not just something that's been directive handed down by the government, but there's a purpose for them, and what is that purpose from the patient's perspective. So that's been very, very helpful for us. The other thing she does is she works very closely with our vendor to understand what has the vendor been able to provide technically in the background to help us meet the needs we have in doing any of our reporting as it relates to current meaningful use measures or, in this case now, the new eCQMs. She coordinates across the Texas area as well, particularly in the Dallas-Fort Worth area, but as many people as we've been able to gather together across Texas so that we are sharing our experiences, and with companies like Encore as well, so that anything that we've learned or done that can save some time and effort for somebody else, that's great, and anything that other organizations have done, we're sharing that data and trying to save time and money for the organizations around us. Right now, she's, of course, very focused on moving towards the electronic reporting needs that we have and aligning that with what we're doing with our quality processes. So to do that, she had to really early on understand what the eQMs were all about and what that meant. And that was augmented by some of our discussions with Encore. And then I think what's really key is she contacted the Director of Clinical Quality, the person who is responsible for all the abstractors that are abstracting that data today for submission to CMS. And that was very, very enlightening for all of us, because I think that was the beginning of the realization of how much mental activity goes into this process by the abstractors that will suddenly be removed as we move to electronic reporting. So working with the EPIC staff and our EPIC IT team to understand how much build we need to do to fill that gap of what is actually documented and what the abstractors need to do to get the data they really need for us to come up with the best possible quality measure based on what is in the chart and what they have to dig to get from the chart, looking at any text that's been put in there. And then learn what data standards we have to take all that text data and put it in so it is actually measurable, discrete data elements. So, of course, understanding all the standard data sets that are required to make sure we're appropriately matching, whether it's a drug, it's a diagnosis, whatever we may be trying to match. And then I think most importantly, her role is to meet with the various stakeholders and begin educating them on what the risk is. So literally going around at the director level. At this moment, we've stayed at the director level to try to educate them on what this change means, the fact that we're starting this year. We got input from them in picking the 4 measures that we were going to report on this year in place of our meaningful use measures, and getting an understanding from them about what does that mean from an operational standpoint that they need to understand and do so that those measures will be at the highest level possible has been key. And now our next step is educating our executives. I report directly to the CEO, and I've had an opportunity to talk to him about this, and our next step will be to do that same level of education across all of our VPs and senior VPs so that they understand, because quality, our reporting of quality is so significant to us in this public environment that we're in. We don't want to weather that opportunity of having those quality numbers go down. We really want them to be the best they can possibly be. So in that regard, we are planning to do an early implementation in the May timeframe so that we can check our results in advance, see how much they've dropped, where they've dropped, why they've dropped, and make those adjustments early before we have to actually report in the 3rd or 4th quarter of this year.
Wow, that's a lot. That's a great answer, and I think that's a great overview, and we'll certainly get into more detail. But I mean, I think you've really framed the issue and the work that's involved. Dr. Wolche?
Sure. At BJC, we actually had some experience in the broad sense using electronic clinical quality measures in that we use some electronic internally developed quality measures for our internal quality scorecards. So at least conceptually, we were familiar with it. Initially, for the meaningful use eCQMs, that was the responsibility of the meaningful use team. And for that, we really just leveraged the functionality that our EMR vendors provided us with. So BJC currently is on a variety of platforms. At our 2 academic hospitals, we're on Allscripts Sunrise, although 2 different implementations for the adult and children's hospital. Our community hospitals are on McKesson Horizons currently. Our medical group is on NextGen. Some of our EDs are on HMed. So we have a very then smaller specialty EMRs. So we have a very diverse environment, and we basically leverage that to the best of our abilities to meet the meaningful use requirements and well, the letter of the requirements for producing eCQMs, and we were able to do that successfully. But as we saw what was coming down the path with a shift in CMS moving from abstracted measures to more electronic measures, we did a review of our results and really found that what we produced from our eCQMs was not in line with what we produced from our abstracted measures. And we had actually partnered with Encore to help us do a deep dive to look at where those gaps were. Many of them we thought we knew, but just wanted to validate that. And it was a variety of things. Some of it was just poor documentation in our EMRs. As Melinda mentioned, sometimes things that are in notes aren't captured discreetly, and so what the clinicians are used to documenting, those data aren't available for eCQM calculations. Some of it was in inflexible workflows. So, for example, one of our EMRs could not calculate VTE prophylaxis unless you used one specific order set. And if you did it, even if you were doing the right thing, if it wasn't captured in that specific order set, it just wasn't calculated properly. And a variety of issues around even using the data that were already existing in our EMR based on how our vendors chose to do the calculations. So that was really our challenge, is how to reconcile what our scores were from the eCQMs versus what we knew we were doing from our abstracted measures. And we had an option of doing a variety of approaches. We could have just forced our physicians to start using the workflows that were implemented in our EHRs to try to capture those data discreetly. That seemed unpalatable. We could have leveraged the data we had and self-certify, and that again seemed somewhat daunting, or we could use an external vendor to abstract the data and then do the meaningful use calculations. And we looked at across a number of potential vendors and thought even our current quality measure vendor might get into electronic clinical quality measures. They chose not to. And so we're actually currently working with Encore to use some of their technology to take the data that we know we have and then produce the meaningful use in CMS eCQM calculations so that we're more in line with what we know from our abstracted results, what our quality is, than what our current eCQM processes are giving us.
Okay, very good. Well, I'm sure we'll get into more detail, and thank you for that answer. Liz, we're going to move on to you with our next question. You've got the valuable experience of working with multiple organizations, looking at different ways people are doing things, different states they're starting at, different problems they have to fix. So can you tell me a little bit about that and what you're seeing as a common challenge that's out there in this area?
Yeah, so many organizations, unlike JPS and BJC, they really have given little thought to their eCQMs. They've been calculating them as part of what's needed to attest for meaningful use, but they've not truly focused on them, so they haven't gotten started. They've really focused on the meaningful use, what we used to call core and menu objectives, where there are thresholds. But now in 2016, organizations are going to have to submit those 4 electronically, the eCQMs for the Inpatient Quality Reporting Program, or the IQR program. And if they don't, that Medicare Market Basket update will be negatively impacted. And although there aren't any threshold requirements or they're not going to be publicly reported in 2016, most organizations are really going to want to submit eCQMs that reflect positively on the quality of care their organization delivers. And at this point, there's not a timeline for the thresholds or public reporting, but we know that's coming in the future. So what we're seeing is one of the initial challenges is understanding their current state. And many don't even know if their eCQM performance differs from their abstracted measures. So once an organization has that understanding of their current state, they can begin to take that deep dive to understand the root cause of those differences. Another area that organizations are finding challenging is understanding where they stand on the certified health information technology with the requirements for submitting eCQMs. Organizations are going to need to work with their vendors and understand their timelines for getting their technology in place in order to submit for Q3 or Q4 of this year. So, and looking at that and how organizations, might be behind, if they haven't started to do this and look at their current state and the requirements for the technology, then they're definitely going to want to get started with this right now.
Right, because Melinda said she started 3 years ago.
Right.
Yeah, and this is, we started over 2 years ago at BJC, really diving into this.
It seems like time is a huge factor in this. You can put in the resources, you can put the people behind it, but there's no making up for lost time, or at least it's going to be very painful. Melinda, does that make sense?
Absolutely.
Right. So you got to get going. Liz, back to your questions. These organizations that we're profiling here, would we say they're ahead of the curve? And then I guess that you described an organization that hasn't even started. That's how you know if you're behind. Is it as simple as that?
Correct. JPS and BJC are definitely ahead of the curve in what we're seeing, and then some of the organizations that we are seeing that haven't even started and don't know where they are, they're definitely behind the curve.
And again, your recommendation for starting is to figure out your current state by doing a comparison between your abstracted measures and your electronic measures, and they can be quite different, and the bigger they are, the bigger the problem you have, correct?
That's correct. That is correct.
Okay, very good. All right, Dr. Walche, obviously you're an MD. We would imagine that's quite helpful in your work. But let's talk about the eCQMs on your job as a CMIO. I mean, we're getting, if we get to this state, and Melinda mentioned this before, the idea of communicating to those who must document better electronically the value of doing so. So can you talk a little bit about that? What is the real value when we do get to electronic quality measures in terms of improving healthcare?
Yeah, this is a real challenge for physicians. They understand conceptually the value of measuring the quality of care they deliver. The challenge is in understanding how, becoming a high-paid data entry clerk improves care, because it really doesn't. That's where really evaluating how you collect data to meet the requirements for the eCQMs is so important, and understanding the physicians and also the nurses and their documentation, that clinical documentation piece, how to collect the data you need in as efficient a way possible, and to merge that data collection in with normal workflows instead of putting in, somewhat awkward order sets or hard stops, things that are very disruptive to the clinical care process. It's a lot of effort, and we're in the process of implementing a new EMR for our system, Epic, and so that's one of our challenges, is how do we best capture the data we need. And again, the physicians realize that this is part of the changing reality in healthcare, but it can be enormously frustrating, and I sympathize. I still practice with, having to enter discrete data that often is already in the system somehow. It's just, in a given EMR, it may not use that data element where it's stored as part of their calculations. And again, this is where we've elected to try to get some flexibility by using an external calculation engine and not being limited to the rules engines that our current EMR providers give us, so that we can take data that we know are already captured and be as flexible as possible in minimizing the disruption to clinical care. And there's a challenge talking to physicians, and again, I think ultimately they get it, but if you don't have clinical people involved in this, you know, I have sat in meetings where people say, oh, well, we can just put up a new form and have them click these boxes off. And, you know, that if they're not clinical people, if they don't take care of patients as nurses or physicians, they may not appreciate how really disruptive it is. And it seems like it's only a few seconds, but, you know, 30 seconds here, 30 seconds there, pretty soon the clinicians have hours of time eaten up with just clicking boxes to meet regulatory requirements, and that really doesn't do anyone any good and doesn't improve the care we're delivering to our patients. It's just a data capture function.
What are your thoughts on the role of scribes? And I don't know to what degree that's proliferating out there, if that's going to sort of increase as more and more documentation is required of nurses and especially physicians, and folks like yourself are getting that feedback in the trenches and looking for ways to make it easier. What are your thoughts about scribes? So
it's clearly a coming trend. In our health system, they're used variably, especially in sort of high documentation, short time areas like the emergency department, where you really can't tolerate any additional documentation burdens. You know, there's pros and cons, and even a scribe can take down the elements of history, but documenting, you know, the decision making. Why did you give VTE prophylaxis? If not, what was the reason not? They still have to. They may be able to enter that data if they ask the physician, but they can't do that independently because you know, they don't have that training. So for the eCQMs, scribes don't necessarily help a whole lot. They will help some, but again, some of this depends on how well the documentation is captured in the normal workflow and where a scribe will help, or it's sort of superimposed on the workflow in terms of checkboxes and all that, and that's where the physician will just be asked the questions, how to check the boxes by the scribe, and so they haven't really, the scribe doesn't speed things up in those settings.
Melinda, let me ask you quickly about your thoughts on scribes, and then when it comes to this area, your relationship as the CIO with the CMIO, I assume you have one of your organization, Dr. Wolche obviously did the CMIO where he's working. Talk about that CIO-CMIO dynamic when it comes to this project.
This is a really fun topic. One of the technologies, by the way, I'm hoping that we can use, and anybody who's on the panel or anybody that's in the audience that has any suggestions around this is, are there ways that we can use natural language processing to convert some of the verbiage from the physician, whether they're dictating or even if they enter it in the system, to come back with putting that data in more discrete fields. We have a vendor who's talked to us about that, and that would certainly be a blessing from a physician perspective if they could dictate and it would correctly put what we need to in text fields and what we need in discrete fields and discrete fields. It sounds like a miracle, doesn't it? But to the question that you asked, we use very few scribes here. We outsource our ED to an organization that's very, very active in the Dallas-Fort Worth area. It covers most of our hospitals here. They do use some scribes, but within our direct care, within our clinics and our hospitals, we are not using scribes. What we have been talking about is linking this process very closely with the CDI people that work in HIM. So remember, they really have this same, for a completely different reason, they have this same interest in really understanding the detailed level of care, the detailed problem, and the detailed level of care being given to the patient. So we have now been working very closely with our CDI team to find out what kind of problems are they having with the data that they're trying to pull from the physicians, just looking at the physician documentation, and what's in coded fields and what's in text fields. And then we're bringing in outside consulting help, so it kind of goes to another question that you have later, but to have people who are very familiar with physician documentation to see, have we really built our physician documentation screens in a way that facilitates entry by the physician as best possible. You know, maybe at the beginning we weren't planning on this problem. So at the beginning we were all just trying to bring something up and get it live, and so we used, you know, we developed things that more like the manual practice the physicians were used to following. Now we're trying to say, could we really change the templates in a way that's more productive and effective for the physician to enter, and for CDI to be able to get their data more effectively as they're creating the appropriate DRG. Well, that is, you might think it's for billing reasons, but it's for a lot of quality reasons as well, but that also helps us get the data in the right place that we need it for the electronic quality measures.
Very good. A couple of thoughts on the CIO-CMIO relationship?
We actually don't have an official CMIO title. We have a director of the EMR person who has been instrumental in implementing EPIC right from day one. And our chief quality officer is an MD, an anesthesiologist. So we actually work very closely with both of them. And I think in both cases, the one that's the director of the EMR is really looking more at the technical side of EPIC and how can we make it better for the physicians. She leans towards the ambulatory side. The chief quality officer leans a little bit more to the inpatient side, and of course he's trying to get better quality care. It's very, very strong focus on better quality care as opposed to ease of use, which is where our director is focused. So those two combinations of how can we improve our quality by better documentation, which is needed, of course, through all our transitions of care for improving our overall quality scores anyway. Those two are working together to give us the input we need, we think, for the appropriate build and to help us with what our final quality outcomes will be.
Excellent, excellent. I'm going to stick with you, Melinda, for this question. What kind of internal resources are needed in this transition, both clinical and non-clinical? You mentioned, you know, you covered abstractors, the clinicians, the vendors, the consultants, but talk a little bit about internal resources, and you could even bring in the idea of budgeting. You have to ask for certain resources, even when it comes to human resources, people you need to hire. Just your thoughts around framing that issue.
Yeah, that is a really good point. We did spend, I'll just be perfectly frank, over $1 million implementing the 3M 360 program. Now, we did that originally for ICD-10, but we are finding that the implementation of that and the natural language processing used for that does now fit into this niche that we're looking at as how to provide better methodologies for physician documentation. So from a budget perspective, that was an enormous task for us. We also have significantly upped our CDI personnel. We were very small. We had started with 2 people, went to 3 people, and now have gone to 8 people recently, and I suspect we'll up that even more because we weren't doing that kind of review of our ambulatory records, and we think they're just as important. So we have upped our staff from an operational perspective and added additional leadership, because there is a new awakening, and I'd love to get input from others on this, about the relationship now of HIM and the electronic medical record and quality measures. I think in the past we've been very siloed. HIM has been very siloed in what they do, and with the advent of the electronic medical record has been more focused on ROI and you know, how they release information and things like that. The CDI people have been more focused on the whole getting ready for ICD-10 and on making sure that we're the best we can be from an ICD-10 perspective. But now, and then the quality team has always been separated because they were doing manual abstracting. But I think those 3 silos are coming together much more significantly now and being staffed at a greater level to be able to understand how each of them affect the others and how we need to have a very clear understanding from the beginning to the end of what the process is, and then what is the ideal process that we need to move to. So aside from having to add some staff, I think that breaking down silos and making sure that everybody who touches this process clearly understands what the ideal flow would be for the best possible outcome for the patient is a key concept that I wouldn't want any of us to miss. we have had to put some really detailed focus in our IT team as well because of all the various data sets, standard data sets that are needed now to do all the crosswalking from what would have been in the mind of an abstractor, but now has to really be done from a mechanical perspective of abstracting data to the coded representation that's needed for the electronic calculation.
Dr. Walsh, you want to give Melinda some feedback on her concepts about breaking down silos?
Yeah, no, I think she's absolutely spot on. Our HIM and CDI programs are starting to work more closely together, but they still don't see quality as part of their responsibility. It's really on that making sure our charts, you know, the severity of illness is appropriately documented, and that we're, ooh, did I just cut off?
No, I can hear you. Oh,
I'm sorry. My phone screen went blank. So making sure that the clinical content is documented, and so quality, when we've talked to them about following up on quality, they really see that out of scope. In terms of resources, we were able to implement our program internally without additional resources. We did repurpose some resources, so we now have a nurse who works for our group manager over quality measurement who's focused specifically on electronic clinical quality measures, as well as the working with the abstractor team who also reports to that group manager. So we've not added a lot of additional internal resources. There is the requirement to you know, if working with external consultants and then, you know, getting that ramped up has required some financial commitment on the part of the organization. But in terms of internal personnel, we've done it by reassigning duties instead of adding staff to take care of this. But it does require that you do have to put people onto that task, because like anything else, it won't take care of itself, and it does require specific skill sets and specific attention to the requirements.
Very good. Liz, I'd like to get your thoughts around this idea of resources that are needed, and if you want to touch on the concept of a PMO, if that makes sense in this case.
Sure. So when we really start to work with clients and we're looking at the assessment of, you know, where do they stand in that beginning stages, and even as we move through to remediate, we're looking at, you know, you need your leadership on board, you need a governance structure, but really when you get down and the rubber hits the road and you're looking at actually doing the work, you really want to make sure that you've got your clinicians involved, and you want to make sure that they understand that patient workflow and how and where the data gets into the system. You also want your IT and reporting subject matter experts that understand the back end of the system where the data resides, and also how those reports are calculating and how they're configured. And you want your eCQM measure specialists that understand the nuances of the specific measures down to that data element level. And once you understand those gaps and you're working through it with that team, you definitely need that strong leadership and a drive by a PMO, a project manager, to make sure that you're driving towards completion of that effort. Excellent.
Very good. Dr. Walche, your thoughts, obviously you've engaged Encore, as has Melinda. Talk about the role of consultants and how they've assisted you, and you know, advice for your colleagues if anyone's thinking of going it alone.
Right. So the value to us was in having a partner who was very experienced in this space. Again, when we first looked at the differences between our electronic results and our abstracted results, we had some ideas of what the issues were, and probably could have teased it out, but working with consultants who were experienced in the domain of electronic clinical quality measures really accelerated our ability to know, you know, what things to look at, what things to focus on. So we did that evaluation step much more quickly than we could have done it ourselves, as, you know, and then having to assign, you know, internal resources for temporarily, or just doing it on the margins, which always takes a long time. Once we had that assessment, then we did spend a number of months internally sorting through our options on how to improve our performance on the electronic clinical quality measures, and again elected to work with a consulting partner to do the data abstraction and then the calculations external to our EMRs, because as we looked at our options, like I said, trying to force workflows, which was unpalatable, self-certification and building it all internally, which would have been a lot of work and, again, very challenging to stay on top of, or working with a partner, again, who has lots of experience in the space. We really thought it made the most sense, really, even economically, to work with a partner. And then in surveying that, we did due diligence to survey the landscape and see, what our options were. So again, in having these conversations, people would want to know what the experience of that consultant is in the electronic clinical quality measure space, and do they really get where the differences are and what the challenges are in collecting those data, and how to find those data in a variety of different EMR systems. So it's really been a good experience, but it doesn't take away all the work. There's a lot of work in getting set up and doing proper evaluation.
Very good. Liz, you want to try and articulate exactly what an organization like yours is bringing to the table for people that want to tackle this issue?
Sure, and it supports what Dr. Wolche said. I mean, basically, our consultants can accelerate both your timeline and your results, and they can bring that proven methodology and tools and experience to the table. Especially in this space, consultants can bring a very specialized knowledge that takes years of experience and research to develop, and those regulations are complex and they're constantly changing, so it's sometimes hard to keep track of everything. And finally, most organizations don't have people sitting around with extra bandwidth, so consultants can come in and they can jumpstart the project, they can run with it, and they can drive results, and then educate and hand the program off to the organization's team.
Very good. Melinda, I'm going to bring you in here, get you a question from the audience. The question is, why was a consultant needed? Was Epic not able to provide the assistance you were looking for?
We used Encore to quickly come in and help us with the concept of what was needed, to give us a little bit of an idea about their assessment and their experience of what it meant to do equality measures and what the effect could be, highlighting the effect of that measure going down significantly when you first run them initially, and the level of workload associated with it. As far as actually doing the build, we've been doing that internally because we don't have the problem that they're facing at Barnes. We have a single system that's costing all of our ambulatory and inpatient areas.
Very good, very good. Okay. Liz, talk a little bit about the regulatory timeline. We talked about how people need to get started. What can you tell us about what's coming down the pike and might give people a little impetus to get moving?
Sure. The shift from value to value in healthcare is underway for both commercial payers and the government. And CMS announced last year that they plan to shift 50% of their payments to alternative payment models, and that would include your shared savings programs, your bundled payments, and your capitated contracts by 2018. And running in parallel to that, they also indicated that they would link 90% of their fee-for-service to quality measures over that same time period. So to date, the eCQMs haven't been tied to reimbursement. With the requirements to electronically submit for eCQMs for the IQR program in 2016, that much anticipated shift from the abstracted measures to eCQMs has begun. So the 4 eCQMs submitted in 2016 will also count for the requirements for eCQMs in meaningful use this year. And based on information that CMS has released to date, we anticipate that the number of eCQMs required each year will increase. So for 2017, 16 eCQMs have been proposed, and each year CMS is going to review and look at the eCQMs. They're going to add new ones. They're going to remove topped-out measures. So organizations are really going to need a programmatic approach to this for years to come, where they're consistently monitoring those changing requirements and performing cycles of analyze and remediate, test, and submit on those eCQMs.
And so,
very good,
Liz,
very good.
I'll just jump in. One notion, and again, this is just my own personal opinion. Historically, CMS has removed topped-out measures because the burden of collecting measures through abstraction has been high, and so with topped-out measures, it's hard to justify ongoing abstraction resources. I wonder if, with electronic clinical quality measures, since the data are being, in theory, captured anyway, those processes are already in place, if the number of measures doesn't just continue to creep, and those topped-out measures may no longer figure into quality payment programs, but they may want to just keep them going to monitor them, because we know historically that once you stop looking at a measure, there can be drift in performance, and so I'm sure they'll review measures. There's actually now very little impetus to take measures away, and just they may just add more and more measures. Again, that's speculation, but I wouldn't be surprised if that were true.
Excellent. All right. Some questions for Melinda. Well, and we touched on this briefly, but talk a little bit about the benefits of starting as quickly as possible, the risks to organizations who think they have more time than they do, and so on.
Well, as everybody's kind of implied, and look, it sounds like even Bonjuice has already made great headway in this area, is being able to run the information now or as soon as possible to get an idea about what your measures are going to look like when you produce them electronically and compare them to the abstracted measure and see what the level of difference is. The sooner you can do that, the more time you have to optimize those results and get to at least 2 where you were from an abstracted perspective, and maybe even better than where you were at an abstracted perspective. So honestly, anybody who waits till the end to just barely make it is going to be, I think, in terrible trouble. It's really important that you be able to do, I'd say, at least 3 runs of this, making sure that you're getting your level of reporting at least to your abstracted level. So I'd be interested to hear what Liz thinks think about that, but I think we'll need at least 3 runs. So I'd be interested to hear what anybody thinks about that. And of course, the problem if you botch it is going to be a very significant impact on payments, and I know we can't afford that. I suspect nobody else can as well. So it is really something that, sometimes because meaningful use was so complicated, a lot of people didn't understand it, and it went to some corner of the room where somebody worked it all behind the scenes, and the operational areas were not that involved and not that understanding about what was going on. That's just not going to be able to happen this time. We are really going to have to publicize what this is, why it is, and why it's so important, because we can't do it from behind the scenes this time. We're really going to have to have our measures reflect what's actually been documented. And it is, we've been very fortunate in that we had lots of education provided by our vendor, which was Epic, as far as what did it mean and what has to happen technically to make it happen. That gave us an advantage to kind of get started early, I think.
Liz, did you want to comment?
Yeah, I would say Melinda's right on in the fact that need to give themselves enough time to understand what the differences are and really remediate those gaps and continue a process of testing and continuous process improvement, especially knowing that they've got to be up on the new technology with the 2015 measure specification. So even as you do this, once you implement the new technology, you're going to have to look at it again before you submit in Q3 or Q4.
Excellent, excellent. I just want to get in maybe one more question. We're getting close to running out of time. Dr. Waltje, the million-dollar question, will moving to eCQMs improve care?
Moving to eCQMs won't improve care per se. It will make it easier, as I suggested, to keep ongoing tabs on the care that's being delivered, so that there's not drift. And again, speculation on my part, I wouldn't be surprised if commercial payers also start requiring eCQMs as well as CMS. So to the extent that it continues the focus on care and quality, it will be helpful. But in and of themselves, they don't improve care. They just document the quality care that's being delivered.
All right. All right, well, that's about all we had time for today. It was an excellent discussion on a very complicated and important topic. So I did want to mention that our speakers today, Dr. Walche and Liz Richard, will be speaking at the HIMSS conference on March 1st from 4 to 5. You have the information there, and you can visit them in booth 6651. So if you want to actually meet our speakers in person, maybe they'll sign autographs. I don't know. Dr. Walche, you willing to sign autographs or what?
Yeah, I'm sure that will be very valuable.
Okay, all right. Everyone's just got to stay calm and form a line. So I want to thank our speakers so much, Melinda Costin, Dr. Keith Walche, and Liz Richard. I want to thank Encore for sponsoring today's event and making it possible. As I mentioned, you'll receive an email when our archive recording has been posted to our YouTube channel within 2 business days, if not sooner. Attending our events gets you 1 CEU towards the CHIME CHCIO program, so let CHIME know you were here. If you've asked us to do so, we will. Sponsorship opportunities, you can contact Nancy Wilcox. Questions, comments, you can contact me. When you close out your WebEx window, you'll see a survey pop up asking you about today's event and our speakers and myself, and we would appreciate you taking a minute to answer that, or less than a minute. And you can go to our website to view our upcoming schedule of events. So I want to thank our speakers, our sponsor, and our audience, and everybody have a wonderful day. Thank you.
Thank you.